Hello everyone, today let's talk about prostatitis. Prostatitis is a term used to describe inflammation of the prostate. Prostatitis is classified by National Institute of Health classification system into 4 categories. First category is acute bacterial prostatitis. Second category is chronic bacterial prostatitis. Third is chronic abacterial prostatitis or chronic pelvic pain syndrome, which is subdivided into 3A inflammatory and 3B non-inflammatory disease. And the last one, fourth category, is asymptomatic prostatitis, histologic or andrologic diagnosis. Those categories are differentiated by clinical findings and by the presence or absence of sign of infection and inflammation in 2 urine samples. The first sample is midstream collection. Then digital prostate examination is done and patient void immediately. The first 10 ml of urine constitutes the second sample. Acute prostatitis is usually due to bacteria. In young adults, that most commonly Chlamydia trachomatis and Neisseria gonorrhea, whereas in older men it's usually Escherichia coli followed by Pseudomonadas. Acute prostatitis classically presents as dysuria with fever above 38 Celsius degree and chills, myalgia, arthralgia, lower back, rectal, perineal, scrotum pain. On a digital rectum examination, the prostate will be warm, tender or boggy. Also, lab analysis of prostatic secretion will show increased white blood cells, and culture will reveal the pathogenic bacteria. Radiologic imaging is rarely indicated, and it's neat if patients don't respond to conventional therapy and if a prostatic abscess or neoplasm is suspected. Treatment with antibiotics is essential in management. Empiric therapy directed against gram-negative bacteria and enterococci should be instituted immediately while awaiting the culture results. Trimethoprim and fluoroquinolones have high drug penetration into prostatic tissue. For example, ciprofloxacin 500 mg orally twice a day or ofloxacin 300 mg orally twice a day. If the clinical response is satisfactory, treatment is continued for about 30 days to prevent chronic bacterial prostatitis. Adjunctive therapy includes non-steroidal anti-inflammatory drugs and potentially alpha blockers if bladder emptying is poor, and supportive measures such as sitz-bath. Rarely can develop prostate abscess, and it requires surgical drainage. Chronic prostatitis, on the other hand, can be bacterial or non-bacterial, such as secondary to previous infection, nerve problems, or chemical irritation. Similarly to acute prostatitis is also present as dysuria, but the key hint here is that the individual is typically afebrile and also complain on pelvic or lower back pain, and also trouble and pain with ejaculation. On digital rectum examination, the prostate may feel normal, tender or boggy. Prostatic secretion will again show increased white blood cells, but culture may be negative in non-bacterial cases. Next is chronic prostatitis or chronic pelvic pain syndrome. The triggers include urine getting into the prostate, previous infection in or around the prostate, problems with nerve pathway, stress, anxiety or depression, and problem with the pelvic floor muscles. Chronic pelvic pain syndrome typically has pain as a predominant symptom, often including pain with ejaculation, pain in perineum, in testicles, and etc. Symptoms of urinary irritation or obstruction also may be present. On digital rectal examination, the prostate may be tender, but usually is not boggy or swollen. Clinically, inflammatory and non-inflammatory types of chronic prostatitis or chronic pelvic pain syndrome are similar. Chronic bacterial prostatitis is treated with oral antibiotics such as fluoroquinolones for at least 6 weeks. Therapy is guided by culture results. Empiric antibiotics treatment for patients with equal or negative culture results has a low success rate. Other treatments include anti-inflammatory drugs, muscle relaxants such as cyclobenzaprine to possibly relieve spasm of pelvic muscles, alpha-adrenergic and other symptomatic measures such as sitz-bath. Treatment of chronic non-bacterial prostatitis or chronic pelvic pain syndrome is difficult and often unrewarding. In addition to considering any and all of the above treatments, anxiolytics such as selective serotonin reuptake inhibitors or benzodiazepines, sacral nerve stimulation, biofeedback, prostatic massage, and minimally invasive prostatic procedures such as microwave thermotherapy.